Yeah, a lot of the time people come to me saying, look, I think I've got keratoconus, so I need this. And when you have a look at them, their vision is clear. You can refract them really well, which means just doing a normal eye examination with a refractor head or a phoropter. You can get them to the 20/20 vision, bottom line chart, just with a normal lens. Then they don't need contact lenses. They need monitoring. They need scanning. They may or may not need a referral for corneal cross-linking, which is a way of treating the cornea to stabilize it so it doesn't progress. And we can talk about that shortly. But that's all the important stuff at that stage. And maybe a pair of glasses is the most important thing because it gives you better vision than your own unaided sight. And it's not bad enough or distorted enough to require something more specific. I can't tell you the number of keratoconus patients that I fit with glasses and soft contact lenses, which normally you wouldn't say would be a thing for keratoconus. But if it's early stage keratoconus, if it's monocular and their vision is still pretty good, then we do the minimum that we need to. We don't need to go to the high level stuff.
No.
If it's a more advanced keratoconus or a more distorted cornea, then soft contact lenses don't give the vision that we require, or glasses don't give the vision that we want. And then we can do fitting with small or medium-sized RGPs or rigid gas permeable lenses, smaller lenses. And then there are larger size corneal lenses as well, which are slightly better and slightly more stable, often with keratoconus. And then we've got larger size, like scleral contact lenses as well, which are designed to dome completely over and mask the entirety of the distorted cornea.
Mm.
And we often think of scleral lenses as being the tool that we go to when the stuff's hit the fan and everything's bad and nothing's good.
Mm.
That's the thing that we go to, but it can be used at any time. It's just a different style of fitting. For some people, they have trouble putting the more hard lenses in and out. They struggle with that, or they don't like. They have trouble with comfort, or they might have an allergy type situation. They might have atopy and they've got really allergic eyes, and sometimes just fitting a normal smaller RGP lens doesn't work for that patient because they've got too many reactions and things. Whereas a scleral lens is often limits that and reduces the allergy response. So it can be a one that'll not only treat the vision and treat the eye, but also prevent the irritation of the eyes as well, or at least reduce it, not prevent it, but manage it in a better way.
And from what I hear, like fitting people with scleral lenses can be a little challenging. Like every fitting has to be sort of customized, and then
Yeah.
there's a whole like training and education process for patients on how to use and take care of those scleral lenses. Is this something that you deal with a lot?
Yeah, absolutely. And I don't think it's not dramatically different to the care and maintenance and the insertion and training procedures that we do for soft contact lenses or corneal hard contact lenses either. It is what it is. You know, there's a process of how do you
Mm.
insert this lens safely? How do you remove this lens safely? How do you look after this lens? And that's the same no matter whether we're dealing with soft lenses, soft disposables that are throwaway, or soft repeat use lenses, or hard lenses that are corneal based, or larger scale scleral lenses. They all have their own process, and it's nothing that's bad. I guess the biggest issue is if we've got people with smaller aperture sizes, so smaller eyes. Scleral lenses are often quite large, so sometimes being skilled enough to be able to hold the eye wide enough open to put the scleral lens in can be a little challenging. But we had a young lady in the practice the other day that we've been trying to fit with scleral lenses, and there's a variety of reasons for this, and I can't really go into that from a privacy point of view. But she's had some issues going along the way, and we got her to put a contact lens in her eye successfully, and she could see with it, or Adam did this week. So, and she was very happy, shall we say? You could hear her from outside the consulting room. She was so happy, and that
Satisfied
was
patient.
lovely. Yeah, really happy with herself, and and because it's been such a long process, and we've tried getting some funding that has failed through various support systems and things to try and help her with this.
Mm.
Yeah, it's. I think that sums it up. I think we don't stop giving. We don't stop trying.
Yep.
We don't stop giving up, even if it's a complicated process. It's a process. It's a journey, and we'll be there with you along the way.
So even sclerals then, so there is a kind of a range of sizes. Like I've heard
Yep.
some talk about mini sclerals. So I
Yeah.
don't know if that's an official
I,
term or
I
not, but I think that the size
yeah.
actually varies quite a bit, doesn't it?
It does vary within a range.
Mm.
The I think a mini scleral really is just a scleral. So that's anything that sits on the sclera is a scleral lens. What we tend to do is we tend to do these large size corneal lenses that are, I guess, would in my brain are almost like a semiscleral, but they don't sit on the sclera, they sit on the cornea, but they're a larger diameter, and we've got a special fitting kit of those as well, which we brought into the practice just recently, which is a new design that I didn't have as part of my repertoire. So there's a lot of different options, and sometimes that's determined by what the patient can cope with, and sometimes it's determined by what the cornea can cope with, and we also liaise with those scans and the maps that we take with the keratograph and the anterior ACT machine. And we liaise with the contact lens labs and say, look, this is what we're getting, this is what we're thinking. And they might come back saying, look, Martin or Adam, this is not going to work. We can't do that. So I think your best option is to either do option B or option C, and option C might be a scleral lens. So sometimes what we're hoping for, what we're aiming for just doesn't pan out. Other times they come back and say, no, I think that's really viable. We'll try that. And if that doesn't work, we'll go to option B. So there's always a backup plan, and by liaising with those contact lens advisors that they've got at the labs, these are people that make lenses for a living. So they're dealing not just with myself as a practitioner, they're dealing with people ordering RGP lenses from scans and other things at thousands and hundreds of practices around Australia, whether they be ophthalmology practices or optometry practices, because both places would fit RGPs and scleral lenses from time to time. So and that means that you've got this wealth of experience and wealth of knowledge that from those labs that they know what they can and can't do. The software of the scans and the raw data of the scans, we often export that to the labs as well with permission, and they insert that into their machines, and then they can put a virtual contact lens onto the eye, and then they can play with different things, very rapidly to try and get a better answer, rather than us doing, 20 fits of someone. We might be able to do a single fit and a scan, and then do a variety of virtual fits to modify those lenses, and then get to the right lens of what we're after on the second attempt or on the third attempt.
So just to summarize then, so for mild cases of keratoconus, glasses might be totally fine.
Yep, glasses, soft contacts,
yep,
corneal lenses, or scleral lenses.
Okay. Newbie question, which is my role here, of course, is to ask all the newbie questions. Orthokeratology, not an option for people with keratoconus?
It's tricky. So with ortho-K, you're trying to change the shape of the cornea to get an effect. What are the risks with that with keratoconus? And the fact there are risks. Could we theoretically do ortho-K after someone's had corneal cross-linking to make the cornea more stable? And the answer is yes, maybe. But again, it's something that gives us always pause. The big mantra that an optometrist keeps in their back of their head is to do no harm. We often talk about that being a medical vow. There's no vow that an optometrist takes. But we're very cautious practitioners. We're not trying to take high risks. We're not stretching the friendship with anything. We're being very cautious with all of our approach. Tried and tested approaches to everything from dry eye to everything else. And ortho-K and keratoconus aren't the best of friends. And I think anything like that we had a question mark in our heads and we were thinking maybe this would be okay, maybe they've had cross-linking or maybe it's a mild case, we would always co-manage that with an ophthalmologist, and in particular an ophthalmologist that's a corneal fellow, so a corneal specialist. And together we make the decision, no, or yeah, let's give it a go, but monitor very closely.